Okay, we're talking about differential diagnosis, so let's get it out of the way. What is it? It's not necessarily a diagnostic method. It is used that way, and we'll talk about that, but it's not necessary. So it's making a list of diagnoses that might fit the patient's signs and symptoms, and then selecting amongst them in one fashion or another, which we'll talk about, to see which one best fits or fails to fit, one that can be excluded from that patient's signs and symptoms. There are two types of differential diagnosis. One is inclusionary, where you positively vet the differential to see if it does fit well, and if it does, great. And the other one is exclusionary differential diagnosis, where you try to eliminate it. Now, on the first case where you're positively vetting, you have to use specific tests. On the second case where you're trying to eliminate them, you have to use highly sensitive tests. So inclusionary and exclusionary differentials. Now let's have a look at the uses of differentials. So diagnosis. It's a diagnostic method in and of itself. Let me give you an example. It's a bit of a funny example, but nonetheless it will work for what we need. We'll use lateral elbow pain. Everybody's familiar with it and so on. Now, the availability heuristic would be this is a common extensive tendinopathy, because that's by far the commonest diagnosis that's going to cause lateral elbow pain. So, but let's go the other way. We'll make a list of differential diagnoses, and we'll positively vet each one. So lateral elbow pain. So what have we got? We've got common extensive tendinopathy. We've got degenerate lateral collateral ligament attenuation or tear, radiohumeral joint problems, radioulnar joint problems, ulnohumeral joint problems, and it can be referred. So now you're going to look at each one of these in turn. So for the common extensive tendinopathy, you would look at is gripping worse than moving the elbow? Is the tendon tender? Is isometric wrist extension painful? Fine, all that fits. It probably is a common extensive tendinopathy. Radiohumeral joint, you're going to have to look at the biomechanical exam of the radiohumeral joint. PPMs, passive physiological movements, followed by arthrokinematic movements if they're restricted, and then maybe some form of stress test to make it reproduce the pain the patient's got. Similarly, you would do the same to the ulnohumeral joint. You would do the same to the radioulnar joint. All of this takes time. It's cumbersome. Now, for the physician, this is the best way to work in most cases. In a simple case like this, he wouldn't do this. But let's say it's a bit more complicated. They would use differential diagnosis in this manner. They would make a list of diagnoses that would fit the patient's symptoms, and make a provisional diagnosis, send it out for the appropriate imaging, lab tests, and so on. Wait until the tests come back, see which one best fits the patient's problem, and there's your diagnosis made. We don't have that luxury. Your diagnosis has to be made in the same session as you see the patient, and you have to generate a treatment plan and probably give him partial treatment, if not full treatment. So differential diagnosis, a diagnostic method for us is useless, really. It's too cumbersome. So we tend not to use it. We'll use some form of hypothetic abduction, which means now we have to generate a hypothesis that we can test, positively vet. Now, exclusionary differential diagnosis can be used for this. We'll go back to the elbow, we'll generate a list of differential diagnoses, but instead of going through the exam for each one, we would use some highly sensitive tests, which, if necessary, would eliminate it. For example, you would test tendinopathy by palpating the tendon. If it's not tender, it's gone. For the radiohumeral joint, the ulnohumeral joint, and the radioulnar joint, we can do quadrants at the elbow. They're very sensitive tests for an articular problem. If they're negative, that's gone. So right now you're down to not much left. The collateral ligament, you can do palpation again. Negative, it's gone. So what you're left with when all these exclusionary tests are gone is referred pain. So this is quick, it's much more reliable. You don't have to rely on the specificity of a test, just on how sensitive it is, which is much easier to gauge and easier to do. You're in and out quickly. This is the best method for us if we're not using some other form of heuristic. It can also be used for bias error mitigation. Let's take the first case we talked about, where you're using a heuristic, an availability heuristic, to say this is a common extent tenopathy. The reason you're using that is because it's available to you. It's what you think of immediately. The reason you think of it is because it's so common, whereas everything else
1, 2,
isn't. So
3,
this
4,
is going to make up
5,
probably 90% of the causes of lateral elbow pain. It works fine, except when it doesn't work. And now your problem is availability heuristic turned into availability bias. And then that's followed by confirmation bias, and then anchoring, and you've got the wrong diagnosis. So if you make a list of differential diagnoses, you can do it with inclusionary or exclusionary, but again, exclusionary is much faster and quicker, easier. So we'll make our list up the way we did before with lateral elbow pain, and we'll exclude these, and there you go, they've gone. If any of them can't be excluded, then you compare this with positive vetting. Now you now do looking for specific tests for that differential diagnosis and see how well it compares with tendinopathy. So it reduces the amount of bias that you may have, if not gets rid of it entirely. Okay, so differential diagnosis. Diagnostic method, a method for generating the first hypothesis in hypothetic abduction, and a means of correcting bias and error. All right, bye guys.